So thanks for the invitation, and thank you for people who are staying to the end of the long second day here. So I'm saying no, do not stop surveillance CT scans. We all do it. Everyone tells us not to, but we should do it. So here we go. There we go. Okay, so don't stop believing this stuff actually works. So why do I say that? Oh, there's my disclosure, sorry. So who says, no, don't do it? Well, my esteemed colleague, Dr. Coleman, is going to say no. Chesson and all those great people who put the Lugano classification say don't do it. NCCN says don't do it if you got early stage. ASH and ASCO, choosing wisely, say don't do it. And the Mayo Iowa Spore date, I'll show you, they say don't do it. That's the only person who says we should do it. So I don't know. It's like, okay. So they assign this to me. They always give me the good stuff. So I came at this thinking, this is really going to be a problem. But let's go through it sort of rationally. So here you have, all the actions in the first 2 years. So if you're going to do it, you ought to do it mostly in the first 2 years. You can see that in DLBCL, relapses after 2 to 3 years are pretty uncommon. So, okay, we're going to focus on the first 2 years. And in the follow-up, this is the same British Columbia data, same kind of thing. And I just amplified that. So you can see that there's about one-third of the patients will relapse in these curves. And, first 6 months, some about 10%, about 15% in the next 6 months, and about 10% in the second 12 months. So that'll come back a little bit later. So, what's the benefit of scanning? It's not going to prevent anything. The question is, does it help us? So what do we do? If we and when we detect a relapse, we want to cure these patients with a stem cell transplant, an autologous stem cell transplant. And so we used to quote people, oh, we got a 50% chance of cure, but if you see in the CORAL study, R-CHOP is great, we do better, but those patients who relapse after R-CHOP, not so good. So we only cure about 20-25% of these patients, so we have a lot of room to do better. But if you get to transplant, it's up around the 50%. So the problem is getting these patients who relapse to transplant. So it makes sense that if you identified these people before they were symptomatic, that you would have a better chance of getting them to transplant and get them, a 50% chance of cure instead of a 20% chance of cure. So in fact, this data comes from Sloan Kettering. It was published 10 years ago. Everything was 10 years ago. So here you go, surveillance imaging, and they looked at their data and they said, who is identified at a routine visit with routine surveillance? And that was about 20% of their patients, that's group 1. And the other patients came with symptoms or pain or some other thing or imaging. And you can see that group 1 does better than group 2. This is overall survival. Now, there's only 20 some odd patients versus 80, so the p-value is not statistically significant. But no one would expect that from a trial of this size. It's an observational study that is sort of hypothesis generating, and you would want your patient to be in group 1. So let's look. So if you're identified early, your age-adjusted IPI is low. That's good. We know that. Your PFS is triple, goes from 1 out of 10 to 1 out of 3 at 5 years. And your overall survival, I have the curve up there. So that should make us all want to scan people and find them before they're symptomatic. So I've taken to looking at some of the editorials which say, don't do it. So here's one, adding weight to a sinking ship, more reasons not to perform imaging. So I adapted this table, and this is what they say. I gave rid of the PET because no one really wants to do PET scans. They're too sensitive. But they say, okay, CT scans detect subclinical disease in 10 to 20%. I'll show you all the studies that actually it's closer to 20%. They agree it's a very sensitive test, not a lot of false negatives. There are some false positives. Low morbidity, we'll talk about. Low cost, cost is an issue. But we don't know if it's beneficial. So their section, they say, okay, we don't know. Well, I would say a couple of things. If I had a 7% nephrotoxicity, I go talk to my radiologist about what they're doing wrong. 3 or 4 CT scans after they've had PET scans, CAT scans, bone, all the other stuff, I don't get too worried about. And yes, there's scanxiety where they're worried about what their scan's going to show, but there's a lot of relief once they walk out after their visit, a lot more relief than if you don't have a scan and they still don't know. And yeah, it cost, but what's the cost compared to, we've already spent over $100,000 to give them 6 cycles of R-CHOP, a couple of bone marrow biopsies, a couple of PET scans, an echo, et cetera, et cetera. So I look at this as insurance on my investment. A few extra $1,000 to like make sure that this patient I invested all this time and effort in is really cured. And yes, can we detect them early where we help them? It's uncertain, but I just showed you data that suggests yes. And yeah, is treatment more effective if it started early? Yeah, no document-proven randomized trials, but I would say the data says yes. And I'll show you some more data. So this is a Danish retrospective look, 6 Danish centers, 258 patients in remission who later relapsed. They say routine imaging, 27% of relapses detected on routine imaging. So again, more than the 10 to 20%, but it's in that same range as the 22% that the Sloan Kettering. And I think that's actually a low estimate, because if you know the scan is positive and you go into the patient's room and they say, I'm still tired from that chemotherapy, oh, they're fatigued, that's a symptom. But if their scan is normal, oh, they just haven't recovered from chemotherapy. So half the CAT scans, half the recurrences were detected at planned visits, not because the patient complained of something. And so what they showed is unexpectedly a possible survival advantage. They did that in the abstract, and a possible survival advantage. Well, I don't know about you, but 38 months when it was detected not by imaging to 90 months with a p-value of 0.008 looks to me pretty good. And the hazard ratio for death is, 40% decrease. So I'm going, they didn't believe their data. They wanted it to come out the other way because everyone's telling them it should, but that's the data. So you have a 40% decrease in dying if you're detected in on a routine scan. So this one I love too. This is another study that looks at cost effectiveness. So there's a Markov decision analytic model, there's quality adjusted life years, and there's incremental cost effectiveness ratios. My eyes glaze over. But their abstract says, overall, we suggest surveillance imaging offers little clinical benefits, substantial economic costs, and unlikely to adversely impact clinical outcomes. So I highlighted all that. Okay, so what's the data upon which they came to that decision? So here's their model. They say, okay, we agree that if you have a low age-adjusted IPI going into transplant, you do better. They said they postulated this overall survival on the upper right on B, overall survival if you relapse by imaging without symptoms. That's about a 3 to 5% increase in overall survival, best I could tell from the graph, which is not insignificant. Now, when you average that over 100 patients, many of whom don't relapse or others who relapse and die, it kind of goes away. But those people, 3 to 5% more survival if you detect them by asymptomatic imaging. All right, and this title was Lack of Utility of Routine Post-Therapy Surveillance Imaging in DLBCL. This is the Mayo SPORE, and they analyzed their own data and a cohort from Lyon, France. And they said, gee, we detected 9 asymptomatic relapses in 552 patients, so only 1.6%, and it was the same in France. And there's no difference in overall survival between those groups of patients if you get detected at scheduled follow-up. And so the data don't support routine surveillance. Well, the data don't support routine surveillance is not the same as the data supports not doing it. That's number one. And let's look at the data. So 9 asymptomatic, 552 patients, that's 1.6. But, 112, if you look at it another way, 104 patients were studied. 112 relapsed, they were missing data. So they looked at 104 patients, 5% relapsed before the first scan, so they don't count. So 80% are cured, 5% relapse in the first 6 months. So you can only benefit 15%. I recognize that. But in that 15%, a third of them were detected at a scheduled visit. And all of them, basically, almost all of them, were by imaging. So I look at that and say, gee, a third of the relapses were detected by scheduled imaging. And so it may be 1.6% of the entire people, of the entire population that got treated. But of my relapses, a third of them scheduled imaging. And again, I wonder about the bias when you say, oh, they had symptoms. I would have said they were there anyway. So they say, only 9 out of 552, and I would say if I accepted their argument, only 22 were identified at a scheduled visit, so maybe we should just tell our patients you're PET negative, go away, and come back if you have a problem. I don't think any of us are comfortable doing that, but the logic is not that far off from saying don't see them to don't scan them. All right, so, and then they said, and there's no difference in overall survival in these patients. So the yellow curves are you relapse at a planned visit. The blue curve is relapse before, so you come in with some complaint. So the Mayo Clinic is on the left and the Lyon curve is on the right. And, you know, yeah, the trend is always favoring the yellow. Now, yeah, we're talking about 9 patients, so of course there's not a huge benefit in the people who are done with scans. But, you know, so it's not statistically significant, but it's suggestive. So, I don't know, it's a political, so factcheck.org. If you detect it at a planned surveillance visit, your median survival in Mayo is 15 months, in France it's 12 months, and your median overall survival if you're detected at a asymptomatic visit with a scan is 21 months and 19 months. So it's about 50% longer, even though it's not statistically significant because the numbers are so small. So again, all the data that's out there suggests a benefit to finding patients with routine scans. So this one I love too, an editorial supporting this let's omit imaging. So here's the data. I'm not going to read it, but my favorite one's on the bottom. It's no longer justifiable in face of abundant evidence that scans don't improve outcomes and considerable risk that they'll hurt patients. So I'm going, So I tried to figure out what actually happened. So here's my model. I showed you 90% are in CR at 6 months, 75 at 12 months, 65 at 24 months. That's the data from the British Columbia. So you get a few extra scans. Not everyone relapsed at that point. So for 90 patients in CR at 6 months, you probably get 95 routine scans, and 10 people have relapsed. And if you believe that you're going to find about 20% just by imaging, 20 to 27% is what I showed you, then you're going to find 2 relapses. And if you do that for each image, you're going to find 8 relapses just by imaging out of 35 patients who have relapsed. And you're going to cure 4 of them based on the Litke data, and the Coral data would have said 2. So I'm saying I'm going to cure 2 of my 100 patients, and it may actually be higher, with 255 CT scans. To me, that's worthwhile. And I don't worry about quality and all this other stuff. It says, you know, if your patient's cured or not, you could probably calculate the long-term expense to the healthcare system as being less. But so it's not a huge number. I understand we're not, you know, saving, you know, 50% of our patients, but I think there's a real sense that scanning can help some patients. So the naysayers say, oh, lack of proof of benefit is the same as lack of benefit. Don't believe that. They really want to rationalize reducing costs, which I understand, but when your patient's in front of you, that's not your main goal. And this is a standard practice. We've done it over years. We're all comfortable with it. And the data I've showed you, while it's not, yes, randomized phase 3 data, it actually, all of it trends in the same direction for some benefit, and your patient comes first. So I'm happy to let Dr. Coleman try to knock me down. I know those other debates. I like those guys, but they were pretty gentle. So today, at the end of the day, I thought I have to get a little wild. So there we went. Okay.